Hi, and welcome back to the ProPA podcast. I'm Angie Urbina, your host for this cardiovascular series. Today we're diving into dilated cardiomyopathy, a condition that's a common cause of heart failure and the most common reason for heart transplantation. Recognizing this condition early is key to improving patient outcomes. In this episode, we'll break down the pathophysiology, who it affects, clinical presentation, diagnosis, management, and key takeaways to help you in practice and on the PANCE. Let's get started. So what exactly is dilated cardiomyopathy? In simple terms, it's when the heart's ventricles, one or both, become enlarged and weak, leading to reduced systolic function. This means the heart can't pump effectively, which can progress to heart failure. The left ventricular ejection fraction is typically reduced, meaning the heart is operating at a reduced capacity. Dilated cardiomyopathy can result from a variety of causes, but when no clear etiology is found, we call it idiopathic. Other common causes include ischemic cardiomyopathy due to chronic coronary artery disease, genetic mutations, which up to 50% of cases have a familial component, toxins like alcohol, radiation, chemotherapy drugs, and illicit substances like cocaine, infections, which viral infection is the most common cause of myocarditis and has been implicated in the development of dilated cardiomyopathy. Chagas disease is another common one. Autoimmune diseases like sarcoidosis and lupus, and other causes are hyperthyroidism, thiamine deficiency, hemochromatosis, and even peripartum cardiomyopathy, which is secondary to hemodynamic changes associated with pregnancy, which can occur in the last month of pregnancy or the first months after giving birth. Regardless of the cause, the end result is the same: a weakened, dilated heart that struggles to pump blood forward, leading to congestion, fatigue, and increased risk of arrhythmias. A mnemonic that may be helpful to remember the causes of dilated cardiomyopathy is the ABCs of dilated cardiomyopathy. It is A, B, C, 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 D. A for alcohol, B for beriberi or thiamine deficiency, C for cocaine, the next C for Coxsackie virus, which causes viral myocarditis, and the third C is for chemotherapy drugs, and D for Duchenne muscular dystrophy, which should remind you of the genetic causes. Now, who is affected? Dilated cardiomyopathy is more common in men, particularly those aged 20 to 60, but it can also affect children and older adults. A strong family history of heart failure should always raise suspicion. Other high-risk populations include individuals with coronary artery disease, chronic alcohol use, previous viral infections causing myocarditis, or those with history of chemotherapy. Regarding clinical presentation, symptoms may develop and progress slowly over time or develop abruptly. Symptoms and signs are similar to those seen with heart failure. Key signs and symptoms include progressive dyspnea on exertion, because as the heart fails, the lungs become congested; orthopnea, which is when patients have shortness of breath when lying down; fatigue and weakness due to poor cardiac output, which leads to systemic hypoperfusion; peripheral edema and weight gain due to fluid retention; and palpitations or syncope due to atrial and ventricular arrhythmias that are common in dilated cardiomyopathy. On exam, you might hear an S3 gallop, which is due to turbulent blood entering the ventricle at different points during diastole, a classic sign of systolic heart failure. Jugular venous distension, rales, ascites, pitting edema, and hepatomegaly may also be present. Diagnosing dilated cardiomyopathy starts with recognizing the clinical picture, but imaging is key. Here's what you need to know. Echocardiogram is the gold standard. It assesses cardiac size, structure, function, and differentiates from other forms of cardiomyopathy. It will show enlarged ventricular diameter, or dilated ventricles, with reduced ejection fraction. Evidence of dilation of one or both ventricles and reduced systolic dysfunction is necessary for diagnosis of dilated cardiomyopathy. Chest X-ray may show cardiomegaly and pulmonary congestion. Electrocardiogram often shows sinus tachycardia, left bundle branch blocks, left atrial enlargement, ventricular arrhythmias, or atrial fibrillation. A B natriuretic peptide is a marker for heart failure and is usually elevated. And you'll want to check cardiac enzymes to rule out myocardial infarction. Now let's move on to the management. The goal of treatment is to reduce symptoms, slow disease progression, and prevent complications. Lifestyle modifications will be necessary, such as sodium restriction and fluid management, exercise as tolerated, avoiding overexertion, controlling blood pressure and contributing factors such as obesity, smoking, diabetes mellitus, or potentially cardiotoxic agents, and alcohol and drug avoidance if toxic cardiomyopathy is suspected. Next, let's talk about the pharmacologic therapy. Patients with class 2 to 3 heart failure symptoms should be on a combination of one agent from each of the following classes of medications: an ACE inhibitor or an ARB, which improves systolic function, beta blockers, which increase the ejection fraction, mineralocorticoid receptor antagonists, and sodium glucose cotransporter 2 inhibitors. And diuretics are used to treat volume overload. Patients with heart failure with reduced ejection fraction who meet specific criteria may benefit from placement of an implantable cardioverter defibrillator, or ICD, for ejection fraction of less than 35% to prevent sudden cardiac death, or a cardiac resynchronization pacemaker. Advanced therapies for patients with refractory heart failure despite optimum therapy include heart transplant and possibly a left ventricular assist device, which can be used as a bridge to transplant. Regarding prevention, preventing dilated cardiomyopathy involves addressing modifiable risk factors such as managing hypertension, controlling diabetes, avoiding excessive alcohol intake, and identifying at-risk individuals through family history screening. Viral myocarditis prevention, such as influenza vaccinations, may also reduce some cases of dilated cardiomyopathy. All right, let's practice some questions. Question 1. A 52-year-old man presents with progressively worsening dyspnea, fatigue, and lower extremity swelling. He has a history of hypertension and chronic alcohol use. Exam reveals an S3 gallop and bilateral rales. Chest X-ray shows cardiomegaly. Which of the following is the next best step to confirm the diagnosis? Is it A, electrocardiogram, B, echocardiogram, C, cardiac MRI, or D, B, natriuretic peptide level? I'll give you a couple of seconds. If you chose B, echocardiogram, you are correct. An echocardiogram is the gold standard for diagnosing dilated cardiomyopathy, as it will show ventricular dilation and reduce systolic function. Question 2. A 52-year-old man presents with progressive dyspnea on exertion, fatigue, and orthopnea over the past 3 months. He denies chest pain, but has had occasional palpitations. His past medical history is significant for long-standing hypertension and a 20-year history of alcohol use. On physical exam, he has an S3 gallop, bilateral lower extremity pitting edema, and jugular venous distension. An echocardiogram reveals a left ventricular ejection fraction of 38% and globally dilated ventricles. Which of the following is the most likely diagnosis? Is it A, hypertrophic cardiomyopathy, B, dilated cardiomyopathy, C, restrictive cardiomyopathy, or D, acute myocarditis? If you chose B, dilated cardiomyopathy, you are correct. The echocardiogram findings of dilated ventricles and reduced ejection fraction confirm dilated cardiomyopathy. His history of chronic alcohol use is also a known cause. Hypertrophic cardiomyopathy typically presents with asymmetric thickening of the left ventricular wall, most commonly to the interventricular septum, and a preserved ejection fraction. Restrictive cardiomyopathy presents with normal or near normal ejection fraction, but diastolic dysfunction due to stiff ventricles. And acute myocarditis can present with similar symptoms, but it is more commonly associated with a recent viral illness, troponin elevation, and wall motion abnormalities on imaging. Great job! A key takeaway is that dilated cardiomyopathy is the most likely diagnosis if you have a patient with progressive heart failure symptoms, reduced left ventricular ejection fraction, and ventricular dilation on the echocardiogram. That wraps up our discussion on dilated cardiomyopathy. Recognizing dilated cardiomyopathy early and optimizing medical management can significantly improve patient outcomes. Thanks for tuning in to the ProPA podcast. If you found this episode helpful, don't forget to subscribe and leave a review. And, as always, this is the ProPA podcast, where future pros in medicine are made. See you next time.